So anyway, so there's the promise. The hope of the promise might be true. That's why doctors are involved in this. They say, well, maybe your promise could be true. These are what's been promised to healthcare providers in our country. Safety, the data will be shareable, it's accurate, no more handwriting problems, it's readable. I'm going to add clinical decision support. I'm going to bring in population health to make this a science. I'm going to be able to do research now. Instead of having 10,000 patients, which is the greatest study ever made, now we're going to have 10 million patients. We'll be able to say, what's the best treatment? What do these drug interactions do? We want to bring up big data, and we want to bring research to a new level. It's going to be fast and mobile, and it's going to enable you to do your job better. It's going to be patient-centered. It's going to be, and patients will be able to bring in the Internet of Me and wearable technology, transparent pricing, texting alerts, mobile applications, smart medicine, get patients connected, bring in home monitoring, and then bring in education and follow-up where we have behavioral modification for like obesity. Maybe IT helps some way to keep them to be strict on their diet. Watson, I don't know if you guys obviously have heard about Watson. It beat the Jeopardy components, their contestants recently, and I guess not too long ago. And so they're moving on to healthcare now. So one day, maybe the promise is that Watson is a better doctor than I am, even though they don't really see it as being taking the place of physicians. They see it as being just this tool you can't live without. So that's the promise. That's why I kind of got on board with this and said, okay, this is what I signed up for. And we're hoping that the growth for healthcare IT is not linear like the bottom here, but we hope that it's exponential growth, and that when we kind of get through the burdens here, we start seeing this take off, the slope go higher, and progress go a lot faster. So that's the challenge for everyone here in the room. How far are we doing? These are the latest numbers from HIMSS, and so I stole these from their website there, HIMSS Analytics website, one of the best websites you can go to if you really want to know how well we're doing here. Just so much data, you can't really process it all. So this is the first quarter for 2015. You see on the right side here, this is EMR adoption for hospitals there, and you see that 50% of the hospitals now are stage 5 or higher, and we see these numbers growing every quarter. What's concerning to me, though, is that the 50% of the patients in ambulatory practice, the doctors in ambulatory practices, 50% are at stage 2 or lower. So a lot of progress to be made there. So anyway, you may ask how we can improve this. So at Baptist Healthcare, and with the help of Craig Dalton, actually this is Craig's program here, we have a new program called Constant Preparation. I won't go into what the constant stands for, but it's really, Craig brought this up in one of his programs, but it's so much to say. I don't like saying big long words, so I've kind of abbreviated it to just constipation. Have you heard of this? No, of course you haven't, because it hasn't come out yet. Thank you. I'm here all day. Thank you. My 12-year-old wrote that joke. Thank you. So, my 12-year-old, we do improv quite a bit here, and he says, "Dad, you got to add this joke. It's awesome. It's a poo-poo joke, and people just love it. It's a healthcare poo-poo. It's perfect." So, anyway, it was a pretty good joke there. Craig did come up with a similar program, but I'll talk to you about it afterwards. So this is an ACO map. You guys are probably very familiar with this, right? These are where the outcroppings of where the ACOs are forming in the country. There's one in Pensacola that Craig and I have been involved with, trying to help them use IT to enable them. You see the big pocket there in the middle part of Florida there around Orlando. Just make a quick, is anybody here from Orlando, in Orlando Health? You guys are doing a great job. I've been involved, talking with you guys quite a bit here because of we're going through an EMR succession there and looking at Allscripts. So we've been dealing a lot with the Allscripts partners there, and back and forth, done a lot of calls with you guys there. So what great work. It's a 7-hospital system, giant healthcare system there, not-for-profit, and they've set a big goal for having the highest quality, being the lowest cost provider in Central Florida. 400 employed docs, and they're trying to put all this together in a population health platform. So they realized they had to identify their patients who are at risk and find their gaps and engage those patients, and then they had to be able to evaluate their physicians about how well they're doing, and they got to do it at low cost, right? So they've done a lot of work on this, and I'm just really proud of it. It's very impressive to me. They've applied for the NCQA, the Patient-Centered Medical Home certification. They've enabled to track physician bonuses based on their quality. Wow, what a great thing for work for quality outcomes. It's amazing. And then be able to pay their physicians for their outcomes. So they've enabled the Medicare shared savings ACO reporting, and they think they've minimized the physician work by removing duplicating documentation. So great work there. And then just for the rest of the time here, I want to talk to you about what we're doing in Pensacola with our Health Information Exchange of Pensacola, SHI. So we're moving on to what we call version 2. Version 1 was like, hey, I can get information from the other hospitals in the area. That's great. How do I make that actionable? How does that get in your face? How does that change what I do for healthcare? Currently, the HIE in Pensacola there has almost 1 million unique patient records, and 95% of the population in Escambia and Santa Rosa counties have records inside the HIE. So our physicians know that. At Baptist, we have several hundred hits a month here. A lot of this from the ER, a lot of this from patients who have to get specialized care in cancer, have to go to our competing hospital, or for OB and pediatrics, they have to go. Basically, the patients are forced to go to different hospitals based on specialty. Cardiology and orthopedics are a Baptist. They do 80% of the cardiology in the counties there. So people at Sacred Heart need to come look at their records at Baptist, so that we make this possible. There are 10 million electronic transitions stored there, and we've had quite a bit of uptime. There's very little downtime with that. So 200,000 transactions a day. I'm going to tell you, that thing is smoking. It is hot. So we have lots of different data being exchanged. Most of the hospitals are on HL7s, where they just kind of exchange everything, but we've also adapted it for CCDAs, the regular CCDs, and then we also bring in other clinical notes from dictations. This is just an overlay of the connectivity of where we're moving to, and not all these are live yet, but these are things that we are working on to get going here. We have retail medicine with CVS Pharmacy. DaVita, if you guys, I'm sure everybody knows who DaVita is. They're the largest healthcare provider for dialysis units across the country. Giant company there, and so we are working on a connection there where all their patients can share information in the Pensacola HIE. And one other thing that I'm really proud to point out here is Point Click Care, and I never heard of Point Click Care. It's the giant company you never heard of. Point Click Care, I think, Greg, was the number 70% in Florida of healthcare. So all the LTACs and the SNF units in Florida, these things, a lot of these companies are you think it's Rosewood or if it's Baptist Manor or whatever, these are owned by Gulf Coast Healthcare. And a lot of them, and then the ones that aren't, they still use Point Click Care as their main EMR for these practices, the SNFs and LTACs. So when we connect to Point Click Care, wow. Now we're closing the loop between being in the hospital to they're going to their long-term care facility and then they're coming back, right? Because it's a never-ending loop for these patients. They don't ever go one place and just stay there. Grandma goes to the nursing home, she gets sick, she has to come back. It's a never-ending loop. So we're helping to close that loop. So IT is fulfilling that promise of saying we're going to come back and we're going to make things better for our patients. I'm going to talk a little bit here about the cancer network in just a second here, but then the mainstays are our big hospitals there in Pensacola. Now, of course, the HIE is attached to the Florida HIE and the Healthy Way network, too. That's just a given. We have a project called HIE Direct, and this works right now where, remember I talked about how 50% of the ambulatory practices are not on EMR. They're stage 2 or 3 or lower. So we had a theory that not, your family physician out in the community, if they're not owned by Baptist Hospital or Sacred Heart Hospital or Ascension, they may not have an EMR. If they do, they've not connected it, and they're not going to pay $20,000 for connection, right? So we have a web portal now where they can log on and with their DSM address here and query the HIE. So when they do that, they fill out the patient's information and their DSM address, and they get the clinical summary of care document emailed back to them to their DSM account as a PDF. So they get all the benefits of the HIE, but they don't have to be a member of it and spend all the money to connect to it hardwired. Does that make sense? So I'm really proud of this because I think this is great for our ambulatory physicians who are in the community. We also have our CareNet. This is allow for physicians who do join up with the HIE to give us their patient registry, and then we can give them ENS or event notification services to let them know what's going on with their patient, whether they're admitted to the ER or they're admitted to the hospital there. So this is what these are not live yet, but this is what we're working on for our version 2.0 to make the HIE more actionable and more appropriate for what's going on in healthcare today. The Cancer Network. So this is in the earliest stages here, and Marion's here with us. I met her earlier here and just doing great work for the cancer patients in our area here. So, I will not do it justice, but I'll just say that there are a lot of cancer patients in Florida, right? Everyone here knows somebody who's had problems with cancer, right? Cancer survivors, people who didn't survive, people who didn't make it. Myself, just about everyone in my family's had breast cancer, and most have done very well with it. So I'm very grateful and thankful for the physicians who take care of me. But just like my mom had cancer 15 years ago, and I have no idea she's not a medical person, so she has no idea what treatment she got. Well, she has a recurrence, has another bump come back up. She's like, oh my God, I gotta get another mammogram. So she gets it done, and her doctor says, great, this may be back. Can you let me know what therapy you got 15 years ago? No idea. She said, I don't know, they put an IV in, I don't know. She has no clue. Well, there were EMR records back then either. It's on paper, right? And if there was, I don't know, it's all discongruent, it's not really connected together, so how would we find that out? So really, she has no idea what her cancer treatment was 15 years ago. So this is what Marion's team is working on, to say that, hey, you have recurrences, they come back, but we need to have a strong record about what happened. So we're partnering with them here, and these institutions here, to form the HIE Cancer Network, which basically says we want to really lock down the communication between primary care doctors and oncologists and health systems who do chemotherapy, who do radiation oncology, those type things, and be able to share information back and forth. So when they come back to their primary care doctor, we know what happened and their treatment plan. So we're proposing this is not live yet, obviously, but this is a cancer treatment summary where we're working on to get there. So instead of the regular CCDA here, we have specific categories for hormone therapy, radiation therapy, chemotherapy, and what surgeries were done. So it focuses on the cancer patient specifically for their treatment. And that's just a page 2 of it there. So also, again, not live yet, but we're working on this. We spent a lot of time on this as our HIE prediction layer, where we're taking the community-wide data package here. On the left side, you see all the things that are already in the HIE. So we're not going out looking for these things. These things are already there in the HIE. And we're looking at this with a computing algorithm, and the big formula there, that's just normalizing the slope there, so it's 1. But we want our predicted value to equal our actual value. So we also can look back and know that we know what the utilization was for patients 3 years ago. It's in the HIE. We've been live for 7 years. Have 7 years of data there. So we know what the utilization was for 3 years ago. We also know what everything on the left side was for 3 years ago. So we can normalize this formula to actually predict utilization in the future. And that's what we're working on. We are working on with a grant with Auburn University now to really trick this out pretty good. And I think in the future, what we'll see is these are not super high-tech companies that come in and do this, but these are open source, like a wiki platform that says we're going to have wiki healthcare analytics. So you can open this up, de-identify the data, and allow the smartest people in the world to work on normalizing these formulas, and I bet we have a lot more progress than we do when it's contained in small companies for very high value. So I know one healthcare system has this formula fairly well tricked out for 3 years here, and they paid, I think, $3 million for that formula. So little hospitals like Baptist Healthcare probably can't drop $3 million on that. But so we hope to open it up and make the information useful for everybody. And we want to come out there where we can predict staffing, care plans, task lists, interventions, what we need to do, and those kind of things too. So that's what we're looking at there. We also have a referral partner network, and I'll just make one comment about that. Some of the data, this is kind of interesting coming out of the HIE. So Baptist Healthcare is a member of, have a pilot program with Blue Cross for an ACO model with shared savings. There's nothing at risk yet, but we looked at that. We took our patients from the HIE and said, well, where are these patients and what are they doing? So from the HIE, we took the data here and said, where are they? So we ran them through a heat map generator here, and we found out these are where our patients are. The red dot there is where the majority of our patients are that are in an ACO. That's in Pace, Florida. It's about a 30-minute drive from Baptist Healthcare. Baptist Healthcare is down here where all the numbers are in the very middle. So when you over that lay where our Baptist Healthcare clinics are, this here, you see Baptist Healthcare is the H right there in the bottom. That we're a long ways. We're a 30 to 45-minute drive away for most of our patients in our ACO. So that's a problem. So using, again, this is actionable data. We say we need to put more healthcare clinics in the Pace area because that's where the population is that we deal with. So again, actionable data. So just to wrap it up, again, the promise. This is what we've signed up for. The Jetsons is what we want to live with. We want to live in that world. And healthcare IT needs to keep up. There are amazing things going on in healthcare. I mean, we're so excited. My kids say, Dad, should I go to be a doctor? Absolutely, yes. The promise is so big. Great things are coming across all of healthcare. Genomics, amazing things here where they're being able to do gene splicing. They're doing 3D printing of organs now. It's just really amazing things that are going on there. Robotic surgery, everybody has a DaVita robot in their hospital now. I saw a first demo of a robot that you actually swallow. You take a couple pieces at a time and swallow it down. When it gets into your stomach, it has magnets on it and it reforms itself and forms into a robot inside you, and then they can control it and move it around to fix ulcers without having to go through these invasive procedures. So, I mean, it's just amazing. I was like, what? This is, it's amazing. So they have a new thing called natural orifice surgery. That's what it's called there. So that's where we're going in the future. We're making progress on these things. Nanomedicine, now they have small machines here that can inject into your bloodstream here that attach to chemical receptors on certain kind of cells. It's the future of cancer treatment, where they can predict these things and they can make these tiny robots that go in and kill cancer cells without having to do invasive surgery. Neurology, I saw the first demo. If you guys don't watch TED TV, you should. I saw this on TED. The first demo of a patch that was like EKG leads they put on this man who was paraplegic and could not feel his legs or move his legs. And they put the EKG leads on his head there, and they trained him to control a exoskeleton. So like in the movie that Tom Cruise was just in, where he wears this big armor thing, whatever, it looked just like that. And through these electrodes on his head, he controlled the legs, and he walked across the room. I've never seen anything like it in my entire life, all using electrodes on his ears. So neurology is making great strides. And certainly as physicians, we're focusing on the stroke care now. It's a quality measure for us, and we're really working and making a lot of progress on that. So, and then at the bottom comes us in the room, connected health. It's up to us to keep up with the other innovators in our field and big data and really come through with a promise. And I don't know if you guys have heard of Kurzweil and his theories here. The guy is just amazing. He has a theory that by 2025, computer processing will keep up with the human brain. So basically by 2025, for $1,000, he predicts you can buy a computer chip that will be faster than your brain, can think faster than you. So he thinks by 2050 we'll have proved that. So he says by 2045 here, he thinks man will be immortal, basically because the people in this room, healthcare IT has made it to where we can now keep up with the promise. So anyway, that's pretty much it. Thank you guys so much for allowing me to talk for a few minutes here. So, keep up the promise.